All right, so I'll go ahead and start the formal introduction. My name is Jess Posner. My pronouns are she and they, and I am the director of the Virtual Y at the YMCA of Central New York. I am a white woman in her mid-30s with brown hair, glasses, and I'm wearing a blue sweater dress. The background behind me is a full bookshelf and some happy plants in a window. It is my pleasure to welcome you to our only Lunch and Learn event this October, featuring our guests Samantha Burke and Alicia Rader from Hematology Oncology Associates of Central New York, located in Syracuse, New York. October is Breast Cancer Awareness Month. The YMCA of Central New York is honored to share a variety of virtual and in-person activities and resources to educate our community and support those impacted by this disease. Here at the Y, we strive to support all of our members in body, mind, and spirit at all stages of life and recovery. We hope these resources will be supportive to survivors, those who care for them, and all people looking to learn more about breast cancer. Our final event this month will take place this Monday, October 25th from 5 to 6 p.m. with Dr. Jane Charlam from SUNY Upstate Medical University. For more information about all of our programs this October and additional online resources, please visit ymcacny.org/BCAM2021. For information on our ongoing Lori's Hope breast cancer survivor support, please contact Sue Montminy at smontminy@ymcacny.org or visit our Cancer Survivors Program, which you can find on the YMCA CNY website. We are recording these events and we'll be uploading them to our YouTube channel and Virtual Y website in the coming weeks. Any publicly shared version of these videos will include only the visual feed of myself and our featured speakers. We will have time for a Q&A afterwards, so if you have any questions, feel free to enter them into the chat at any time, or because we're a small group, we can just kind of unmute and chat with each other afterwards. Now, I would love to welcome our guests this afternoon.
Hi, my name is Alicia.
I'm Samantha.
And I actually have a bio for you guys. Sorry, I was just turning off my notifications actually. Oh. So it was ding-dinging all day long. All right, so we have Samantha and Alicia who are joining us from Hematology Oncology Associates. Samantha Burke worked as an RN at St. Joseph's Hospital on a medical surgical unit for 6 years and obtained her FNP through Upstate Medical University in 2016. She then began working at Hematology Oncology Associates of Central New York with Dr. Kirshner, caring for mainly breast cancer patients, actively participating in breast cancer research. She is nationally certified through the American Academy of Nurse Practitioners and an active member of Oncology Nursing Society. Alicia Rader was a nurse for 5 years in the medical intensive care unit before obtaining her master's from Upstate Medical University, then becoming an NP at Hematology Oncology Associates. She has 2 children. Her daughter is 6 and son will soon be 3. She has a dog named Kramer who is 9 years old and was a rescue. Alicia works directly with Dr. Scalzo, primarily seeing breast cancer patients, but also cares for all cancers and hematologic disorders. She truly loves connecting with patients and caring for their overall well-being, mind, body, and spirit. And it is our privilege to have you both here with us today to share your wisdom and your experience and your expertise. And I now turn it over to you.
Thank you. All right, can you see that okay?
Looks good.
So just some basic statistics here that in 2021, there was an estimated 200,081 women in the US that will be diagnosed with an invasive breast cancer. Approximately 49,000 of them will be diagnosed with a non-invasive breast cancer. There are men that breast cancer can affect as well, just over 2,000. The average 5-year survival rate for women with non-metastatic invasive breast cancer is 90%. Breast cancer is the second most common cause of death from cancer in women in the United States after lung cancer. Women dying from breast cancer has decreased by approximately 41% from 1989 to 2018 due to the great works and efforts we have with early detection and treatment improvements. So who's at risk? The female gender increases with age, so that can increase your risk. If you have a strong family history of breast cancer or a personal history of breast cancer, that also increases your risk. Patients with genetic predispositions such as the BRCA mutations, P10, TP53, PELB2, among others, can increase their risk. If you've had radiation to the chest or face before the age of 30, and those women with dense breasts are 6 times more likely to develop breast cancer, and that can be harder to detect on mammogram. Some additional risk factors for breast cancer are early menstruation before age 11 or 12, late menopause that happens after the age of 55, women who've had their first pregnancy later in life after the age of 35, women who have never had a full-term pregnancy, or people who have had hormone replacement therapy after menopause. Oral contraceptives can slightly increase the risk, and there's still more research going on for this. There are more white women than Black women, but it's more common in Black women over the age or less than the age of 45 than white women. Women of Ashkenazi Jewish descent or Eastern European heritage have an increased risk as they're more likely to have inherited that BRCA1 mutation. The American Cancer Society recommends that women age 40 to 44 have the choice to begin annual screening mammography. If you're known to have dense breasts, the recommendation is to add an ultrasound or to consider 3D mammography. We follow the NCCN guidelines, the National Comprehensive Cancer Network, which recommends annual screening with mammogram plus breast MRI for some women who are at higher risk of breast cancer. So that includes if you have a genetic mutation, a relative that's first degree with the known genetic mutation, and other mutations that can increase the risk of breast cancer that are mentioned on the screen. If you've had the radiation before the age of 30 or a greater than 20% lifetime risk of an invasive cancer based on family history. There has been an increase in young women being diagnosed with breast cancer, Rates of breast cancer are low in women less than 40 years old. Fewer than 5% of women diagnosed with breast cancer in the United States are younger than the age of 40. Rates of breast cancer can increase after the age of 40 and are high in women over the age of 70. The median age of diagnosis of breast cancer in women in the United States is approximately 61 years old.
So genetics in breast cancer, about 5 to 10% of breast cancers are thought to be hereditary. Hereditary cancer testing can help identify if you carry a gene that increases your risk of breast cancer. Testing is being used more often now. It is now covered more by insurance. And if you have a known genetic mutation, you can take steps to actually prevent cancer, find cancers early, making them more curable. We do offer this genetic testing at Hematology Oncology Associates, and we have specific genetic counselors who sit down with our patients and talk about the risks, the benefits, and possible outcomes and results with patients. And we'll go over the results and options they can do to help prevent cancer. Most commonly used test kits are MyRisk and Invitae, and some known genetic mutations associated with increased risk of breast cancer are BRCA1, BRCA2, TP53, P10, STK11, PELB2, CHEK2, ATM, and so forth. Who should have genetic testing? So if you have a family history of anybody diagnosed with breast cancer under the age of 50, 2 breast cancers in one relative at any age, 3 or more breast cancers in relatives on the same side of the family at any age. Some of the more rare cancers like ovarian, metastatic prostate, pancreatic, or male breast cancer at any age within the family. Colon, rectal, or uterine cancer diagnosed under the age of 50. A gene mutation found in another family member would qualify somebody to have genetic testing to see if they have that same mutation. Others, if you yourself have a personal history of breast cancer at any age, ovarian cancer at any age, metastatic prostate cancer at any age, pancreatic cancer at any age, and colon, rectal, or uterine cancer under the age of 65. So if you're younger when you're diagnosed, would qualify you. The process is pretty simple. It's done through a blood or saliva sample. Results usually take about 2 to 3 weeks. And the possible results, they find a genetic mutation that increases the risk of cancer. You could come back with an elevated result, meaning they looked at your genetic makeup, but didn't find a genetic mutation, but overall feel that you are at an increased risk of cancer, more so than the general population. And a negative result, meaning they did not find any genetic mutation and they don't feel that you're at any increased risk of cancer, more so than the general population. Occasionally, they'll find a variant of uncertain significance, which is a change in a gene, but they don't know the significance of it yet, but it will be researched with time, and you will be notified if it ever comes to be known that it does increase the risk of a certain cancer. How are these results beneficial? If you test positive for a genetic mutation, your parent, brother, and sisters and children have a 50% chance of having that same mutation and would be eligible for testing. There's different things you can do to help decrease your risk of cancer, such as risk-reducing surgeries. So women with the BRCA1 or the BRCA2 mutation may opt for surgery to lower their risk of cancer. That's usually a prophylactic mastectomy, which appears to reduce the risk of developing breast cancer by 90 to 95%. They could also consider removal of ovaries and fallopian tubes, which can reduce the risk of ovarian cancer as well. Women with an elevated risk of breast cancer should discuss with their doctor about drugs that may help prevent the risk of breast cancer as well. Some drugs that are used are tamoxifen. Those are usually used in women that are premenopausal, around 35 or older. And then there's Avista, which is used for women who have gone through menopause. There's also aromatase inhibitors like anastrozole and aromasin, but they haven't been approved yet for the risk reduction setting. And if preventative surgery or medications are not a great option for you, you can discuss increasing surveillance to help detect cancers early, such as alternating mammograms with MRIs every 6 months. And if you yourself want to know if you're a candidate for genetic screening, you can use this QR code, and the directions are right here. You open the camera application on your smartphone, you hover your camera over that code, and a link will appear, and you can click it and take an online risk assessment survey, which is a lot about family history, and it'll help determine if you qualify for genetic screening. So you will know your eligibility for cancer genetic testing at the end of that survey. We do offer appointments to meet with our genetic nurse practitioners here at our office. You don't have to be an active patient. You can call our office and get set up, or email cancergenetics@hoacny.com if you're interested.
Sure. Genomic testing that's used in breast cancer is used to diagnose breast cancer and help determine the appropriate treatment options for patients. With this option that's available with the genomic testing, sometimes chemotherapy is less used because it's been proven that it's not necessarily needed. Genomic testing is available and can be done on the sample of the tumor that was removed during your biopsy or surgery. Some examples that we use are Oncotype DX and MammaPrint scores. There's also molecular testing to look for different mutations. PDL1, we're looking for MSI instability, and certain genes like the PIK3CA gene mutation. So depending on those results can then determine whether or not there's more so targeted therapy available for you. So the Oncotype DX score is used on patients with estrogen receptor positive, progesterone receptor positive, and HER2 negative breast cancer that is not involved within the lymph nodes. This test will calculate a recurrence score after looking at 16 cancer-related genes and 5 reference genes within your tumor, and it estimates the risk of recurrence outside of breast cancer within 10 years of diagnosis. This can help doctors make decisions on whether you would benefit from chemotherapy in addition to hormonal therapy, or determine that chemotherapy would not add any benefit. So patients less than 50 years old, who have a recurrence score less than 16, chemotherapy is usually not needed and they can get by with just hormonal therapy. If you fall within the range of 16 to 30, we should consider chemotherapy before hormonal therapy. And then if it's greater than 31, chemotherapy is recommended along with hormonal therapy. If you're older than 50 years old and your recurrence score is less than 26, we could get by with just hormonal therapy. If it's between 26 and 30, we should consider chemotherapy before hormonal therapy. And if it's greater than 31, we would recommend using chemotherapy. You can limit your risk of breast cancer with lifestyle modifications, limiting alcohol to no more than 1 drink a day, maintaining a healthy weight, staying physically active. Breastfeeding can play a role in prevention. The longer you breastfeed, the greater the protective effect. Limiting postmenopausal hormone therapy and following a healthy diet. For example, women who eat Mediterranean style diet supplement with extra virgin olive oil and nuts can have a reduced risk of breast cancer.
Then we just have some closing remarks here. Always be vigilant and aware of your breasts. Report any changes in either breast right away. If you notice any changes like skin thickening, dimples, nipple changes, discharge, or lumps, call your doctor for an evaluation right away. You should always discuss with your doctor the proper time to start mammogram, and be aware of your family history of cancer. And that's all.
Thank you so much. I'm going to add myself here to the spotlight. That was so informative. And it is also so clear that there's been a lot of advancements in terms of detection and screening and also treatment over the last decades. You know, I come from a family who for generations has been afflicted with breast cancer. So to see even just the changes that have been made in the last 20 years, right, is actually quite impressive. So thank you for your work and also for sharing those with us today. We did have a chat that came in through one from our guest, Emily, who asked, what classifies as quote unquote dense breasts and how would you know if you have them?
So that's, from what I can comment on this, would be something the radiologist classifies depending on what the imaging looks like on your mammogram. If they feel that your breasts are dense or increased risk because of that, they'll ask for follow-up imaging with an ultrasound.
Okay, thank you. Does that answer your question, Emily? You can pop it in the chat or unmute yourself if you'd like. Okay, she says yes, thanks. I have a question. So I had heard in the past that in terms of like family history, that it's really just the matrilineal line that you need to worry about. Is that still best knowledge? Like, for example, like if you had a grandmother that had breast cancer, but then your parent is her son, right? Is there still the same kinds of risks that you still need to be thinking about? Or is it like is there less of a risk because it's a patrilineal line versus a matrilineal line directly to that person?
Yeah, I think it's still a risk. You definitely want to look at patterns too. Like if there's 3 or more, generations on that same paternal side of the family that have had breast cancer, I think, that, you're still just as much at risk and need, qualify for testing to see if there is some mutation on that side of the family.
Okay, thank you. I wanted to ask both of you actually, how did you get into this work? So that's my first question.
That's a great question. So coming from the ICU, I had very little experience with cancer myself. My grandmother had lung cancer. I had another grandmother with thyroid cancer. So I also have some cancer in the family as well. But this was very eye-opening and a new profession for me to come into the oncology world from this standpoint. And I've learned a lot and grown through this, and I love it.
And I am a cancer survivor. When I was 20 years old, had cancer. So it's just something I thought I could relate to patients and really help them through because I've been through the majority of it. So, and it's something I enjoy doing and helping patients.
Thank you so much for sharing that. As a follow-up to that, I also, I mean, we are now going on 2 years, right, in one of the most challenging things that many of us have faced in terms of living in a pandemic. And you both are working in an already stressful professional environment where people are having what may be the worst times of their lives. So I was curious, how do you continue to fill your own well during this time so that you can continuously serve your patients?
I still try to do most of the things that I enjoy outside of work, like, regular exercise, getting outdoors, enjoying the weather, doing things in a safe manner that don't put, myself or patients at increased risk of, COVID, and just taking time for myself, but still being there for patients and my work and everything. So
I would have to say very similar. I've tried to keep life as normal as possible despite COVID. I have 2 little kids at home, so we play outside and are active in that way so that I can, release myself and relax as well. And we still have to be here for our patients. So we have to do all of this smart with COVID and stay healthy ourselves.
Thank you so much for that. So, I feel like your presentation was so thorough and I learned so much. And you've been very generous with your time in terms of providing this information with us. But I'm just curious if you have any final words for us before we sign off from this really informative lunch and learn session.
Just be vigilant, like we said in that last kind of slide there. Just always, don't wait. If you think something's wrong, go ahead and get an appointment with your doctor. It's, it's worth it to be checked out rather than to wait it out. And, it's something, and it, gets worse with time. So just always seek, care and discussion with your doctors regarding your risk and when to start screening and all of those things.
And no question is too silly. Sometimes I have patients say, oh, I've been waiting and, I was worried to ask you about this. I didn't want to bother you. Like, you're not a bother. If something is wrong, you're concerned about something. If that light bulb is going off saying, hey, something doesn't feel right or something doesn't look right, don't wait. I mean, that's what we're here for. That's what all of your providers are here for, is to see you and help you. So please call.
All right. Well, thank you so much, Samantha and Alicia. It was a pleasure getting to share this time with you. And I just wanted to extend our gratitude from the YMCA of Central New York. And I know, and I've actually heard around the Y when people saw that you guys were giving a talk, that they were like, oh, those were my nurses, or, my nurse practitioners, or like, oh, I had such supportive experiences at HOA. And I'm so grateful for the care and support that I got from them. So please know that you are respected and appreciated from our Y family, and we really appreciate and are grateful for the work that you do. So thank you so much, and I want to wish everybody a nice Friday and wish you a good weekend.